Hi, my name's Erica Auger, and I'm the clinical manager for behavioral health here at Spectrum Health Medical Group, and I manage a team of social workers or behavioral health specialists who are embedded in primary care. Today we're going to talk a little bit about universal screening for depression and anxiety. So we're going to review together today why screening for behavioral health conditions is so important. We're going to review the screening tools selected for primary care, and we're going to introduce the universal screening standard of work. But first, let's talk a little bit about why we would screen for behavioral health in primary care. So one of those reasons is that we know half of all Americans will experience a behavioral health condition sometime in their lifetime. And we also know that comorbid behavioral health conditions can impact a patient's medical outcomes, and it can increase the cost of health care by up to 75%. Lastly, depression is the third most common reason for a visit to a medical health center after diabetes and depression, or after diabetes and hypertension. Again, health outcomes for patients who have a behavioral health comorbidity are impacted. We see that patients have a greater symptom burden. The presence of both conditions can create complications in the treatment and the overall treatment for patients. We also know that patients who have behavioral health conditions have a harder time adhering to their treatment plans. And again, behavioral health comorbidities can drive up the cost of health care, and that additional cost is mostly in medical, not mental health expenditures. So now that we know why we're screening for behavioral health conditions, what specifically are we screening for? We're using the PHQ-4 to screen for both anxiety and depression. And we screen for both anxiety and depression because it's very common for patients to have both of those conditions at the same time. Some studies show a 50% or more rate of comorbidity with anxiety and depression. Let's go back to that slide. So when you look at the PHQ-4, again, it's a 4-question tool. Question 1 and 2 are specific to anxiety. Questions 3 and 4 are specific to depression. Patients are asked to respond to each of the following statements on the PHQ with an answer of not at all, several days, more than half the days, or nearly every day. So they're asked to score the symptoms on a scale of 0 to 3. The PHQ-4 is located on the Active Visit Navigator, and in most practices, screening is occurring verbally by the medical assistants during the rooming process. We often tell patients that screening or that asking those 4 questions from the PHQ is really our new vital sign. We do it for every patient at every visit, just like we would take a blood pressure, a height, a weight. We're asking the PHQ-4 questions. Some offices, because of their unique layout or their unique workflows, do use paper versions of the PHQ-4 at the time of check-in, and the medical assistant will collect it and enter the information into Epic during the rooming process. But best practice really is to ask those questions verbally during rooming. So what happens next after the PHQ-4 is completed? When the PHQ-4 is completed in Epic, any additional screening will cascade automatically as appropriate. So if a patient were to score a 3 or more on the first 2 questions, which, if we remember, are about anxiety, that will automatically cascade a tool called the GAD-7. If a patient scores 3 or more on questions 3 and 4 of the PHQ-4, which again are about depression, the PHQ-9 will automatically cascade or populate. Now, if a patient happens to be between the ages of 12 and 17, an adolescent version of the PHQ-9 will populate. So going back to the GAD-7, This is an anxiety screening tool. It's 7 questions. It is scored the same way as the PHQ-4. Again, patients are asked to rate symptoms on a scale of 0 to 3. Patients can score anywhere between 0 and 21. 0 to 4 would tell us that they're having minimal or no anxiety. 5 to 9 is mild anxiety. 10 to 14 is moderate. And 15 to 21 would tell us that this patient may have severe anxiety. The PHQ-9 is our depression screening tool for, again, depression. It has 9 questions, again, scored the same way as the PHQ-4 and the GAD-7. Only patients can score 0 to 27. 0 to 4 is minimal or no symptoms. 5 to 9 is mild. 10 to 14 would be moderate symptoms. 15 to 19 is moderately severe. And 20 to 27 is severe. The nice thing about making sure these questions are asked right away and put into Epic is that Epic does calculate for us the score, so folks don't even have to add up the numbers. Epic does that for us. So here you'll see a link to the standard of work for universal screening. This page, or this piece of standard work, is located on the ambulatory and hospital outpatient department standard work page on Insight. The standard work includes best practices, so what we've learned over the course of the last 2 years about screening, what works best, and how to engage patients in universal screening. So I would encourage everybody to go to that site and adopt that standard work for your office. In addition, there are other tools that are available for helping your site roll out universal screening. Operations specialists have been trained on how to roll out universal screening and can help you implement this process. There's a toolkit that's available that provides tips for success, such as considering a phased roll-in of screening. There's a memo of understanding to help your team document your plan, and there's scripting for both the medical assistants and providers about how to engage and talk with patients about screening. And of course, we have some sites who've been screening for the last couple of years, and we've learned some lessons that I'd like to share. Phased-in screening has been very successful for most sites. Whenever you're implementing a new process, it can be a challenge to do that across the board with all providers and all patients. So many offices have selected 1 or 2 providers to start screening their patient panels to begin with. Finding a provider champion, a provider who feels very comfortable with behavioral health and with screening and talking with patients about their overall behavioral health, can be a good place to start. Experimenting with screening methods. If your medical assistants are uncomfortable with the idea of asking the questions verbally, can we do a couple experiments? Maybe one medical assistant is asking the questions verbally, maybe one is using paper, and how do we compare and figure out which method works best for your site? Commit to 2-week trials, though, if you experiment. Behavioral health can be difficult for some folks to talk about, and it can be difficult even for our staff to ask those questions. So be willing to really commit to 2-week trials of screening. It may be uncomfortable, it may feel inefficient at first, but if you're patient, your teams and your staff will become more efficient and more accustomed to engaging with patients around their behavioral health. So what should an office do for patients who do have an identified need? So if you have an embedded behavioral health specialist, you should refer to him or her for patients whom you identify through screening have a need. For those offices who don't have a behavioral health specialist, We do have a centralized social work queue that's available to provide telephone support for patients who have an identified behavioral health need. And you can see there how to make that referral. It's a referral 98 to social work. And for patients who have needs that may require face-to-face intervention, and again, you do not have a behavioral health specialist in your office, you can see the referral numbers for both psychiatry and psychology, as well as the main phone number to our PBM division. So in summary, we know that universal screening for depression and anxiety helps us care for the whole patient. Patients who have a comorbid behavioral health condition see challenges, or patients who have a comorbid behavioral health condition have difficulty adhering to treatment plans. They have a greater symptom burden. Their cost of care is impacted. Their ability to care for their overall health and wellness is not the same. So being able to identify these patients helps us not only care for the whole person, but to make sure that we're giving each and every patient the same opportunity to use each and every tool available to achieve their health and wellness goals.